Hello, and welcome to my presentation on opioid-induced constipation. Today I will be talking to you about some of the symptoms of OIC, some of the ways to manage OIC, some of the latest research studies on the treatment of OIC, and some of the ways we can implement evidence-based practice to facilitate protocols for change in our places of work. So the first thing we need to talk about is what is opioid-induced constipation. So it is defined as a change in bowel habits due to long-term or chronic opioid use. And these changes can include decreased frequency, hard stools, straining to pass stools, and or a feeling of incomplete bowel movements. Now, the reason this happens is because when you take opioids for a long time, peristalsis, or the muscle contractions, slow down and the motility of the gastrointestinal tract is decreased. It's very common in patients on long-term opioids. Up to 50% of these patients experience OIC, and between 30 and 50% of patients in palliative care settings experience this problem. OIC may sound like a small problem, but in actuality it has a big impact on both patients and the healthcare system. It greatly affects a patient's quality of life. When you are constipated, it is a miserable condition. It can even cause depression in some patients. Other symptoms can include acid reflux, fecal impaction, obstruction, infections, and as far as the impact on healthcare, it can lead to burdensome sequelae, such as increased medical procedures and tests, labs, and quite a significant economic burden when you compare these patients to patients who are not taking opioid medications. So there has been a lot of discussion on what OIC is, and now we move on to what are the traditional therapies used to treat OIC. So typically one of the first things providers will do will be to question patients about their routines and their bowel habits and any laxative use before they start opioids. This way they have a baseline of what is normal for the patient. If a patient begins to experience OIC, there are several things that can be done. You can reduce the opioid dosage. However, in doing so, you may also inadvertently increase the patient's pain. So this is a tricky one and not always effective. Providers may also choose to switch to transdermal preparations, which have been shown to cause somewhat less constipation than oral medications. And these include fentanyl and buprenorphine patches. Some of the other recommendations are typical for any constipation, encouraging exercise and increasing water and fiber intake, although these aren't always effective for OIC. If some of the traditional therapies are not effective for OIC, you can move on to some more intensive therapies, and these include polyethylene glycol, PEG, or commonly known as Miralax. You can use enemas and even suppositories, although these aren't always totally effective for OIC either. There is a new class of medications called peripherally acting mu opioid receptor antagonists, or PAMORAs, and these medications include methylnaltrexone, naloxegel, and oxycodone naloxone. These have been proven to be somewhat more effective in OIC, which can be refractory to more traditional therapies. So now we move on to naldehyde, which is the main focus of the treatment section for my presentation. This medication is in the class of Pamoras, like the medications I had just mentioned. However, it is the only medication that is strongly recommended from the American Gastroenterological Association. It does not interfere with opioid analgesia, meaning patients do not experience a decrease in the effectiveness of their opioids when taking this medication, which can occur with some of these Pamora medications. This particular medication, naldehyde, does not interfere with analgesia because it has a reduced ability to cross the blood-brain barrier. So there have been many studies on the safety and efficacy of naldehyde in treating OIC. I looked at 3 of these studies, and I found overall that naldehyde is safe and effective in treating OIC. The first study looked at naldehyde in OIC patients who had chronic non-cancer pain, and these were Japanese patients. This study showed few side effects, and when side effects did occur, they were mild, and things like diarrhea, nasopharyngitis were the most common. Serious reactions were rare, and more importantly, patients showed improvement in bowel function within 2 weeks of starting the medication, and also reported increased quality of life in patient surveys. In the second study of naldehyde, these patients also had OIC and also had chronic non-cancer pain. The safety of the medication was similar. It was well tolerated by most of the study subjects, and the side effects were generally mild and included mostly GI-related side effects like diarrhea, flatulence, and nausea. As far as effectiveness, patients had increased frequency of spontaneous bowel movements after starting the medication. And in my third and final study on naldehyde, these patients were slightly different in that they had OIC, but they had chronic cancer pain, which is different than the first 2 studies. Again, naldehyde was safe with no serious adverse events, and diarrhea being the most common side effect, and generally tolerable and effective. Patients had less feeling of straining and incomplete bowel movements and increased rates of spontaneous bowel movements. So when we look at any research studies, we should critically appraise them for their level of evidence. There is a level of evidence pyramid that shows what types of studies are the most reliable and the most likely to give you good, valid information. So with study number 1, this study falls into a level 2 on the evidence pyramid, in that it is a subtype of a randomized controlled trial. It was a open-label, single-arm, phase 3 study. Study number 2, again, falls onto level 2, in that it is a subtype of a randomized controlled trial. It was a randomized, double-blind, placebo-controlled, parallel group phase 2b study. And study number 3, similar to the previous 2 studies, was a randomized, double-blind, placebo-controlled treatment period. There was also a subsequent 12-week open-label extension, and this, again, is a level 2 on the evidence pyramid. It's a subtype of a randomized controlled trial. So all 3 of my studies fell on level 2 of the levels of evidence pyramid, meaning they are generally considered to be very reliable information in the research field. So overall, I found that naldehyde is very safe and effective for OIC. Now the question becomes, how can we institute change at our facilities, at our places of work, to incorporate this medication into treating patients with OIC? Implementing change in clinical practice. So anytime you think about implementing any change in a practice setting, you have to think about the culture of the workplace. Workplaces should be able to provide you with clear communication about what they expect. They need to give you goals based on evidence-based practice, what they want to see happen and how. They need to give you the ability to connect with upper management and CEOs and discuss your concerns with them. They need to provide support to mid-level management, such as nurse managers, who oftentimes are charged with implementing these changes on their units. And nursing committees can also be very important, as nurses are on the front lines, and workplaces should allow nurses to drive change and evidence-based practice protocols from within their own units. In order to implement a facility-based protocol, evidence-based practice needs to be used. And as you can see in the Venn diagram on this slide, evidence-based practice consists of several areas. You really need to consider the current research and what that states is effective. You need to consider patient preferences and staff preferences, and even the type of unit and facility you are working at. Once this is done, it is a good idea to incorporate your protocol into the electronic medical record. In this way, you can assure that staff are following the protocol as they are performing their documentation. So in conclusion, OIC is a common problem, but that doesn't mean it's not a serious problem. It can be very debilitating for patients and very costly for the healthcare system. There are many therapies available, both traditional, more advanced therapies. They're not always effective. The medication nalmefene has been proven to be safe and effective, and I found corresponding evidence for that in the 3 studies that I looked at. All of these studies have a high level of reliability according to the levels of evidence pyramid. And I think as a nurse practitioner, I would feel comfortable implementing a nalmefene protocol at my facility. This protocol could do many things, the most important of which is to relieve patient suffering and relieve their OIC. It also may prevent complications down the road, such as obstruction and impaction and other things that can cause patients to have more medical problems. And lastly, it can decrease the financial burden on the facility or the workplace by preventing these complications and additional healthcare expenses. So I thank you for listening to my presentation today. I hope you have enjoyed and found it informative. Thank you very much.